So welcome everyone to this clinical toxicology round organized by MENATOX. So we can please share your questions later on in the discussion or chat box. Today we have two excellent cases, and this is, a special edition of this clinical rounds because we are sharing the competition, the case of the competition that we did in the that was organized by Dr. Afra Al-Suwaidi during the MENATOX conference in Riyadh 2026. So let us present our distinguished panelists today. Our Professor Nuzha Brahmi. She serves as Professor of Intensive Care Medicine at the Faculty of Medicine, University of Tunis, El Manar, since 2014, and was the head of Department of Medicine at the same institution in 2024. Professor Brahmi is the head of the Department of Intensive Care and Toxicology at the Mahmoud Yacoub Center of Toxicology in Tunis, which since 2016 she did multiple researches and papers that you can have insight or check online. So her professional affiliations include serving as director board of the Middle East in the board of MENATOX, and she is also an active member of the Tunisian Society of Intensive Care Medicine and other multiple societies. Thank you for joining us, Professor Nuzha, and welcome here.
Thank you very much. It is a pleasure for me to be with you today to discuss about two cases. I think two interesting cases. Thank you for the invitation.
Thank you so much. Thank you. So because we are running out of time, so let us begin with our first case, focusing on carbon monoxide. I will now hand the floor over to our first presenter, Dr. Manar Shehhi, resident in emergency medicine in Oman. So I will now floor is yours, Manar. So walk us please through your presentation.
Okay, good afternoon, everyone. It's my pleasure to present again our clinical toxicologist cases in the grand round. And thank you to Dr. Afra to give us these opportunities. Okay, so we'll start with our case. Dr. Samia, you will move the slide now?
Yes, dear.
Okay, sure. So we'll start, yeah. So our case is about 17-year-old male who was previously well with no past medical or surgical background and brought to the emergency department by EMS. According to the paramedics, he has been a day fishing trip with his friend and no other information found. Next slide. Okay, so in the pre-hospital assessment by the EMS, the patient was with his friend at the scene near the beach. He was like tachypnic, unconscious, and query pinpoint pupil, in which immediate 1.2 milligram of naloxone were given, followed by oxygen supply. Patient was partially improved after this intervention. Next slide. But unfortunately, the friend who was with him, he was found pulseless and declared dead at the scene. So only the second friend who brought to the emergency alive, semi-unconscious with tachypnea and improving mildly with oxygen supply and that naloxone dose. Next slide. So patient brought to the emergency department, the patient received, connected to monitor, and the primary survey was done for him. Airway were patent with no stridor. Bilateral air entry saturation was about 90% in room air. improved with non-rebreather mask. Blood pressure was maintained as well, but then started to drop with heart rate between 55 to 45, 45 to 55 in this range. RBS was fine, GCS was 12, pupils bilateral reactive 3 mm. And this is the picture of the monitor immediately upon the arrival of the patient. So primary survey showed picture of some hypoxia with bradycardia and hypotension as well. Next slide. So patient clinically deteriorated, persistent desaturation despite oxygen via face mask and non-rebreather mask was there. Blood pressure started to drop again and NORAD infusion initiated for hemodynamically support. Next slide. So the system examination, we started already the intervention. The patient was started on NORAD, intubated as well. Eye was mildly looks like pinpoint and reactive. No other eye issues. CVS was bradycardia and hypotension with no chest pain or any other symptoms of exertional chest pain. Respiratory wise was having shortness of breath, tachypnea, and no cough, and no other systems involvement. And other examination were unremarkable. Even the patient was febrile with no features of sepsis as well. Next slide. So investigation, pH, this is a VBG of this patient. pH was 7.25, PCO2 51, O2 was 12, lactate was 5.3, bicarb was 19, and potassium was 3.8 with sodium of 135. This was the initial VBG. Next slide. So in line with the bradycardia and the hypertension, ECG was obtained immediately, and this is the ECG. It's not that much clear in the presentation. I'm not sure why, but I think we can appreciate if there is any significant ischemic changes in the ECG. If any thoughts about this ECG, you can share it in the comments. Any thoughts? So this is the immediate ECG. The heart rate is about 55, 50 in between. May saying that there's inverted T waves. Yes, there is some inverted T waves in V5 and V6 as well. Why the QT is not that much, but might be. Biphasic T wave is another possible change as well. So Hepaside bradycardia, T wave inversion, yes, it's almost all your comments are going with this ECG. So it's a bradycardia with non-specific changes. There is no clear ST elevation, but investigation were sent, including troponin as well, although the patient denied any chest pain. Next slide. And this was the chest X-ray of the patient, the immediate chest X-ray. And we can see that looks like infiltrates is there. Okay, so now with this immediate assessment of our patient, with the vitals, initial investigation, ECG, X-ray as well, what do you think is going on with this patient? What are the list of our differential diagnoses?
Thank you, dear, for this, sharing this insights with us and outlining like the initial part. Pausing here. So we pause clinical narrative here to engage the audience. So we would like to know from you, our audience, what are the differentials you are thinking of. So if we think so what is specific toxicant? For sure we are in toxicology here, but also other etiologies are, we need also to know about other etiologies. So think about it. You are there in the ED for this patient presenting with this profound hypoxia, elevated lactate, CNS depression, and so with another simultaneous fatality. So just we wait for the audience to respond here. And also I would like to ask to engage our Professor Nuzha Brahmi following this initial pre-hospital and ED presentation. If you can share with us, Dr. Nuzha Brahmi, insights, and also let me read. Bismillah.
Excellent.
Yeah,
Here, I think if we have to summarize this case, donc, we are in front of young people who's find in altered consciousness with a disease of one of his companions in a confined space. So we have one patient with one disease in a situation of enclosed space with severe acidosis, with hypoxemia, and with an altered cardiac dysfunction. So here we have to think about a toxic situation, an inhaled toxic. Here we have two hypotheses, carbon monoxide or cyanure, because in this situation we can think about cyanure. But here lactate, the level of lactate in the blood is not so high, because in situation of poisoning with cyanure, the lactate must be higher than 5 millimole per liter.
Yeah, I
Here,
agree.
I think the diagnosis is clear. I think it is very easy diagnosis here, because we have all the circumstances, clinical situation, and we need to confirm this diagnosis by doing the dosage of carbon monoxide hemoglobin.
Here we can see in the chat they are mentioned. Amal mentioned it is inhalation injury, carbon monoxide. Wafa mentioned possible asphyxiant, irritant exposure. So yeah, so I agree, Professor Nuzha, about when we have like a presentation. Sometimes maybe if we have like hypoxia and we have presentation mimicking opioid overdose, pinpoint pupils, we may think about it. However, having like the oxygen often confounds the perceived clinical response to the naloxone. Also, as you mentioned, we need the screen. We need to check the carboxyhemoglobin level, which is really important. The cyanide point also, I agree on that. And for this patient, we have this the myocardial issue or cardiac dysfunction. This is something really important. We can speak about it later as well. And also, like when we think about the oxygen for these patients, it can help. Only one point I would say is if we take long time, before sending the lab for carboxyhemoglobin, it may be forcibly, dropped forcibly, like given the treatment given, which is the oxygen. But let's see the remaining of presentation. Manar?
Excuse me, Semia.
Yes,
I have
please.
to add that for carboxyhemoglobin, I know that it dropped with the time, but after I think after 4 or 5 hours, it will be stabilized, and it is very important for the medical legal diagnosis, I think. A second point, I think, I don't know if we will speak about it for the cardiac dysfunction. And here the particularity is the cardiomyopathy disease attached to carbon monoxide, which is the Takotsubo syndrome, or the broken heart pathology, which is, I think, pathognomonic of this type of poisoning, and it was first time described with carbon monoxide. I think it is very important to focus on this cardiac defect.
Yeah, I agree. It's really important to consider that as well, and to rule out other poisonings. We can resume, Dr. Manar, just to continue for the presentation, and then after this part 2 of this case, we will answer questions and discuss more before going to the second case of this edition of our
Okay,
session.
sure. So thank you so much, Dr. Nizam and Dr. Samia. I really like the comments. It's like really a wide variety of differential diagnosis. I really appreciate that because most of the audience here, I don't think they did attend the MENATOX, so they are not sure about what's going on with this case. So I can see there is calcium channel blocker toxicity, there is inhalation injury, there is asphyxia as well, and methanol and opioid overdose as well, which is really good amount of differential diagnosis. Okay, so let's move to the next slide. So we continue this is the importance of POCUS in the emergency department as a point of care tool. So bedside echo was done for this patient, as any patient with a bradycardia, hypotension, you will put your probe just to see what's going on. So bradycardia, hypotension, found that ejection fraction of this patient is 30 only, or 35 by eyeballing, with dilated LV with a global hypokinesia, although he was 17 years old with no past medical background, because the patient's relatives attend after that. We talk further history. Was no clear history that the patient is having any cardiac abnormalities before, not on any medication, and there's no family history of sudden cardiac death or any cardiac abnormalities. Next slide. Okay, so CBC showing some element of neutrophilic leukocytosis, the WBCs of 25, neutrophils of 21, and lymphocytes of 2. So there is ongoing sepsis is there with the CBC as well, but let's see what's going on in the further slides. Next slide. Urea and electrolyte showed an ion gap of 19, because we can see in the initial VBG there is element of acidosis with bicarb 19, chloride is fine, creatinine, potassium, sodium, and others are unremarkable. Next slide. Troponin was 70, as there is bradycardia, hypotension, with that unclear non-ischemic changes or non-specific ECG changes, in which troponin was sent, showed of 70, which is elevated, but still we need to compare it. So second trop was sent, and urine drug screen was negative. For those who were asking about opioid and the pinpoint, this is a real case. So still, as per the EMS, it was query pinpoint, not sure what's going on, but urine drug screen was negative, no injections mark, and no bottles of alcohol or smell was there. So it was like giving naloxone just in case, but there's no clear evidence at the scene. Next slide. CT brain was done for this patient as well, and no evidence of acute intracranial insult noted. Next slide. Okay, so here regarding the differential diagnosis, we already discussed, and I can see Dr. Yasin is mentioning a bradycardia, hypotension, altered mental status. Think about beta blocker, calcium channel blocker, clonidine, or digoxin. With asphyxiation as well. We do agree with you, Doctor. This is very important differentials. But now, in the next slide, we will reveal the important clue for our diagnosis. Next. So the toxicology was consulted for further evaluation and management in the context of potential toxic or metabolic etiologies. Next slide. So the thing that we didn't reveal, so here, so the infectious workup was there because of that neutrophilic leukocytosis, possible bacterial infection, although patient was febrile, but he came semi-conscious, so we are not sure if there is any other signs of infection, but on a clinical examination, there was no rash, nothing. Cardiac assessment, cardiology was involved as well. Next. Okay, Dr. Muhammad is telling that any clinical indication for ordering troponin in the absence of chest pain in a awake patient, actually with non-specific ECG changes, and the patient is having bradycardia with hypokinesia in the LV dysfunction was there as well, with non-specific ECG changes, initial elevated troponin in 17 years old patient. So that was like a reasonable explanation to send a second troponin. Are we missing something? Shall we send the patient immediately to cath lab or what? That was the issue. This patient was admitted to the under medical team in the Heidi for cardiac monitoring and supportive management. Next slide. So the EBG, as we mentioned earlier, actually intentionally we hide this information because this information was the biggest clue in our case. So pH of 7.25, BCO2 of 51, lactate of 5.3, potassium of 3.8, sodium is normal. Next. And the carbon monoxide level in this case was 41.8%, which is very high in such cases. As we know, carbon monoxide should be up to 5 in non-smoker patient and up to 10 in smoker patients. So 41.8 with hypoxia, some element of a bradycardia, hypokinesia as well, semi-unconscious, and we get the information from the EMS that the patient and his friend were in a closed car. They were in a fishing trip, they finished, and they went to the car to take some rest. They opened the AC, they closed the car fully because the weather was a little bit warm, and the car was a little bit of old brand, like very old car. Maybe it was like some issues with the AC or something was going, as per the investigation by the EMS. Looks like strange odor was there when they opened the car, and both of them were unconscious, but one of them was already pulseless and confirmed death on the scene. So that's why carbon monoxide toxicity was the top differentials in our case. Although we continue with the further investigation, someone is asking about the metal screen. Yes, it was sent and it was negative as well. So next slide. I do really appreciate the wide differentials. Dr. Alexander is telling he was fishing. Yes, did they catch or eat anything? There was like fish, like in the ice box, but there is no element of rash or history of eating fish or any history of bite or any mark. So dilated LV, global hypokinesia, ejection fraction of 30 to 35, IVC was normal as well. Next. So this patient with high carbon monoxide, already oxygen supply was given, and we consulted toxicology back. Next slide as well, because this is repeated. Okay, yeah, so our toxicologist advised for immediate hyperbaric oxygen therapy because this patient not improving despite having 1 hour of non-rebreather mask, and with the second hour still he is not picking up, with BB still fluctuating with the NORAD and bradycardia as well. Mild improvement was there with the NORAD. When the patient was a little bit stabilizing, we send the patient to the hyperbaric and then discharge with outpatient cardiology follow-up. At 1 week review, the patient remained well. So here the thing that was about the carbon monoxide induced cardiotoxicity with the importance of hyperbaric oxygen therapy.
Thank you so much, dear. Thank you so much, Dr. Manar, for this insightful presentation. Let me give let me ask Professor Nuzha. Floor is yours, Professor Nuzha, for any insight regarding the case before we go to the next case. I believe it's really, really important to mention the physiopathology of how, because usually what we think about only respiratory failure or hypoxic patient, but thinking about the dysfunction the cardiac dysfunction, thinking about this carbon monoxide binding to myoglobin with affinity greater than binding to hemoglobin, causing this, impairing myocardial contractility and precipitating cardiogenic shock. This is really important. However, for this young patient, this is something I would say it's rare.
Thank you, Samia. I can add for the management of this type of poisoning here. I think that hyperbaric oxygen is considered as the antidote for this intoxication because we have to give a lot of oxygen under a high pressure to separate carbon monoxide from hemoglobin. Here there is more than one indication for hyperbaric oxygen because there is altered consciousness. One of indication altered consciousness. 10 indication there is defect of cardiac function, and third indication because the level of carbon monoxide in blood is very high and it exceeds 25%, and it is one of the indication of the recommendation for experts. So we have at least 3 indication for hyperbaric oxygen indication. We have to emphasize on the treatment equally of the cardiogenic shock. Here we have to give supportive treatment and tonicardiac treatment, and even hyperbaric oxygen is considered one of the treatment of this cardiogenic shock. So I think we told about all the aspects of this intoxication, clinical aspects, management, and I think the prognosis here could be very dangerous because we have a disease and this patient was in very dangerous situation, and I hope for him after hyperbaric oxygenation he cover after hyperbaric oxygenation. And for cardiomyopathy defect, its evolution is good and it is favorable. In 3-4 days all recover, and the cardiac function recover, and I think that his left ventricular function grow up than 50 or 60% after 3 or 5 days.
Thank you so much, Professor Nuzha. I agree for what you said about the management exactly, and also I wanted to mention that we frequently hyper-focus on the delayed neuropsychiatric sequelae of carbon monoxide, but this acute myocardial suppression driven by the cytochrome C oxidase inhibition and also profound catecholamine surges can be immediately fatal. So this one, for this case, the rapid normalization of the ejection fraction following the hyperbaric oxygen therapy show us or underscores the critical importance of neutralizing the mitochondrial poisoning effect of carbon monoxide, which extends far beyond simply reducing the carboxyhemoglobin level itself. So the literature, as you said, like I mean, the case reports on the Takotsubo cardiomyopathy induced by carbon monoxide poisoning. This serves as a reminder that I mean. Aggressive or early toxicology intervention is really important to alter this, I mean, trajectory of both, I mean, cardiac and neurologic toxicity. And this is what makes this case, I mean, delicate. And fortunately, they had, I mean, think about everything and confirm this labs on time. Also, I would insist on something which is for us usually what we think when we have, I mean, a case like this. I mean, we tend to think about the risks. So for us, the risks for this usually we think it's about having high age, having predisposed patients to have, I mean, this a critical presentation. So I want to answer some of the questions that we have here. 1 second. So I will just...
Samia, before answering this question, we continue in the same field. Here, I think in predisposed patient, we have to look for coronary angiography after recovering, because we can have some stenosis, or so after recovering, we must indicate a coronary angiography in predisposed patient. Other thing you have said that for neurological or delayed neurological sequelae here, carbon monoxide hyperbaric is a good treatment for sequelae, because actually there is no data about its efficiency in acute situation, but it is recommended for prevention of delayed neurologic sequelae.
Yeah, also as per the recent population, I mean, based cohort studies, they indicate the increased risk for this myocardial infarction is for the first month post exposure, and mainly it affects high risk groups, like for example the females, individual for pre-existing liver disease, or many, I mean, patients with that. So that's why these patients, like, it's rare, as Dr. Manar said, the family, they don't have this underlying conditions for them, or I mean, hereditary problems. Let us just answer some questions here. So we had a question, I think, about opioids. Let me just start with it. So about opioid. So the question was, the question was how this cause pinpoint pupils. So like simply pinpoint pupils, they are something like, it's classically suggests an opioid toxidrome. It's true, however, it's something empiric. It's not something specific for that. So it's not exclusively pathognomic for opioids, because it's a direct manifestation of severe global hypoxia that may happen with any other, I mean, toxic, I mean, agent which cause this effect. So profound tissue hypoxia and early anoxic brain injury can precipitate this, I mean, autonomic dominance, or resulting in meiosis. So the second question we had about thinking about methanol. So methanol, this is something we think about altered mental status, that we check the anion gap. So this is all that we need to consider initially, for sure. The other question we had, troponin, already Manar answered about it. because for troponin, it's important, to consider that. For this patient, when the patient having bradycardia, hypoxia, hypotension, so we need to think when it's an explained collapse with lactic acidosis, we need to have these cardiac biomarkers as
Also,
priority to
Samia,
evaluate
he
the
has
cardiac
a diffuse repolarization abnormality, and it is one of the indication to make this marker.
Yeah. Thank you, Professor Nuzha. Another thing that you mentioned regarding the efficient trip. So marine toxin is something that we should also think about in aquatic environment, for instance. So ingestion of something can precipitate, for example, improperly stored fish, for example, the massive histamine release, maybe the puffer fish. We have many others. However, like the timeline, profound metabolic derangement, and differential. So, that carbon monoxide, we have, fortunately, we have the level for that. So they rarely precipitate actually this fish exposure precipitate isolated severe cardiogenic shock and lactic acidosis, and also immediate simultaneous fatality of co-exposed individual in the scene. All of this, so the sudden death, all of this, because mainly the other cause may have time to work. So I think, so for how long they might have been exposed, it depends actually on the concentration. If it's like high amount of carbon monoxide is there, poor ventilated, so the time, given the time, so it should be like, without aeration, it should be like quite long. However, I think Manar, they don't have insights regarding the time, right? Time of exposure for this case.
Yeah, as per the EMS, it was unknown. They approximated as 2 to 3 hours because people in the beach found them like looks like sleepy in the car. They are not sure what's going on, so they called the police. That's why.
Yeah. Thank you. So we can now go to the next second case. We are running out of time, so we'll, if you are the audience, if you are available just to continue with us, we will try to make it rapid for the second case. Dr. Hiba, resident in emergency medicine in SKMC Abu Dhabi, UAE. The floor is yours.
Everyone, it's a pleasure to be here. I hope that my voice is clear. Can you confirm that, Samia?
Yes, my dear.
Okay. So I'm an emergency medicine resident from Sheikh Khalifa Medical City in Abu Dhabi, UAE. So let's dive in. Next slide. I want you to meet our patient here. He's a 23 years old male who is known to have multiple psychiatric disorders, and he has a history of sleeve gastrectomy, and we'll highlight why this might be related to his case. And he uses alcohol, occasional alcohol use, and is a regular vape smoker. Other than that, he has no illicit drug use. So on October of last year, our patient was found in his room after he had ingested 160 tablets of his home medications. This happened 30 minutes exactly prior to presenting to our emergency department. Next slide. So as you can see here, his initial vital signs are pretty much unremarkable, except for an elevated blood pressure of 172 over 107, and the rest were within normal limits. His initial physical examination was unremarkable. And Samia, can you go back to the previous slide? He was actually seen in a low acuity bed, and the initial physician that saw him had given him activated charcoal. Next slide. ECG was obtained and labs were collected, and the patient was connected to a cardiac monitor. Next slide. Give the audience a few seconds to look at the ECG, but it was pretty much unremarkable. His QRS was within normal limits. His QT was within normal limits, and as you can see, this is a normal sinus rhythm. Okay, next slide. These were his initial blood results. This is a venous blood gas and the rest of his labs, as you can see. Just take a few seconds to look at them, but everything was within normal limits. And this was the rest of his investigations, his urea and electrolytes, his renal function, and additional paracetamol, salicylate, and ethanol levels. All were negative. Okay. Wafa, to answer you, we will reveal his medications. That's part of the discussion today. So all of this, as you guys can see, that this is all the calm before the storm. The patient was initially vitally stable. His labs were unremarkable. His ECG was within normal limits. So 1 hour later, our patient begins to deteriorate. So next slide. He goes on to have generalized tonic-clonic seizures. It was terminated with diazepam and he was transferred to the resuscitation area. As you can see here, this is exactly how our patient looked like. He was post-ictal, disoriented, confused, excessively diaphoretic. His repeat vitals revealed a blood pressure of 170/89. He was tachycardic, tachypneic. His saturation was normal and he remained normothermic. A repeat physical examination revealed inducible ankle clonus, and his pupils were 2 millimeters equal and reactive. Okay, Samia, next. So Samia, just go back a little bit. So our patient continues to have 2 more seizures that were refractory to two doses of 4 milligrams of IV lorazepam. So at this point, he was in status epilepticus. Next. He then goes to become hypotensive, so he's now in shock. So the decision was taken to intubate this patient and protect his airway because he was in status epilepticus, and his blood pressure was eventually stabilized using norepinephrine. And the patient was eventually transferred to the ICU. So on the way to the ICU, after stabilization of the patient, I see this rhythm on the cardiac monitor. The audience can comment on this ECG. Remarkable about this ECG. VT, monomorphic VTAC. We can, as of now, we can at least say that it's a wide complex tachycardia, right? Sami, just wait. Okay. So when the patient was taken to the ICU, as they saw this initial ECG rhythm, they gave the patient 100 mics of sodium bicarb, given that they know that this is an overdose case. They gave him 150 milligrams of amiodarone, and they repeated his ECG. And this is what you can see after all of these treatments. What you can notice here is that the QRS is now even wider, despite the following treatment. Okay, so Sami, next slide. So this is our ED timeline, just to summarize the entire case. He, at time 0 was the time of ingestion. He presented 30 minutes later after ingestion. Activated charcoal was immediately given. He has a seizure 1 hour later. He continues to seize. His blood pressure drops. He now requires intubation, norepinephrine initiation. He then develops a wide complex tachycardia that is not responsive to sodium bicarb and amiodarone. So I'll just open the floor for discussion.
Thank you, Hiba, for this insightful presentation. And let us think. So let me ask the audience to submit their differentials in the chat. And let us think. So let me give floor or open the floor for Professor Nuzha for any insight for this initial. Actually, I want to say to the audience that this is a special edition of clinical rounds where we don't reveal all the data in the first part. So this is actually the approach of this. It was a competition actually in the MENATOX. So that's why we are not revealing what are the drugs, to open more the floor for discussion, and then after this the second part will reveal there the what we found and also what was the management fully. So Professor Nuzha, the floor is yours.
Here we are in front of young people who had a history of psychiatric disease and who is under psychiatric medication. And he was he took 160 tablets of his medication, and in few times he get toxidrome with anxiousness, I think, and tachycardia, initially tachycardia. And he, after 1 or 2 hours, I think his situation become dangerous, and he developed, especially and particularly, an intraventricular, I think, arrhythmia. And he altered his consciousness. Here, for me, at first, I have to think about antidepressant. And as I said in MENATOX, the first diagnosis for me was stabilizing, I think, critical stabilizing membrane syndrome. But I know that it is not the answer, because I think that a lot of participants think as me, because I know in Tunisia, I know the diagnosis. In Tunisia, we don't have this type of molecule. But at first, I think about antidepressant, which lead to cardiac toxicity here. Seizure and cardiac toxicity, for me, it is an antidepressant, I think. If I have to resume, here there is a seizure, refractory seizure, with cardiac abnormality and intraventricular block. I think here, this is the diagnosis, the first diagnosis for me, that the molecule is an antidepressant molecule.
Thank you so much, Professor Nuzha, for the insight. And then we also need to see what they mentioned in the chat, just to have, because we didn't reveal anything, just to have to see the discussion where it goes. So we can see here serotonin syndrome. We can here see the TCA, amiodarone is contraindicated, TCA. So this is pharmacovisual formation should be suspected for multiple dose of isolated charcoal. Yeah, so we can see many differentials here. So let us, because we are running out of time, actually, let us resume Dr. Hiba. So we try a little bit to be fast for the second part, please. So we can allow a short discussion at the end and answer if there is any questions.
Okay, so let's go to the next slide. We'll just go quickly back to our patient. Toxicology were consulted and they had advised us. Sam, you just go back to the previous slide. So toxicology was consulted at this point, and they had advised us to start the patient on intralipid emulsion. And this was because they knew what the agent was, and we'll discuss what the agent is in a bit. And as you can see here is the repeat ECG. Can we just show the ECG, Samia? ECG. As you can see here, once the patient had received the intralipid emulsion, you can see normalization of the QRS complex with the repeat ECG. Okay, next slide.
Excuse me, Manar, is molar bicarbonate solution given or not before antralipid solution?
Yes, it was given.
It was given, but there is no impact in the QRS
There was no
manner?
improvement. It got
No improvement.
yeah.
Okay.
Okay. So his hospital course continued he was extubated 5 days later. He was weaned off vasopressors. He remained in the ICU for 10 days and he was stepped down to the medical wards where psychiatry had assessed him. Next slide. These are the highlights of our case. He's on a psychiatric medications. He has a wide complex tachycardia. Samia, previous slide.
So what?
My dear,
previous-
just we mentioned that which medications they have because we don't have much time, so they know the case actually. Please
Okay.
continue.
All right. So what I want to highlight here is that this patient is on a sodium channel blocking agent that also causes seizure. However, what is unique here is that this is a medication, this is a drug that does not respond to sodium bicarbonate. So the medications that he was taking were bupropion and venlafaxine. And actually, he took 90 tablets from the bupropion, so this was the higher dose, and the venlafaxine was 60 tablets. Next. So just briefly, bupropion is a synthetic cathinone with slight modifications in its chemical structure. Next. So it works by inhibiting the reuptake of dopamine and norepinephrine at the synaptic level. So what happens is now you have higher levels of dopamine and norepinephrine. Next. So general therapeutic uses, it's commonly used for depression and off-label use as for smoking cessation, ADHD, and obesity, which this patient had a combination of. So for its pharmacokinetics, the majority of the drugs in the market are the extended release formulations. So the peak plasma concentration occurs at 5 hours, which means that the onset of the toxicity can be delayed. It has a very high volume of distribution and protein binding, meaning that it's not a dialyzable toxin, and it is metabolized in the liver into the pharmacologically active hydroxybupropion, which has an even longer half-life of 20 hours. Next. So mechanism of toxicity is related to the high levels of dopamine and norepinephrine. As you can see here, it causes agitation, tachycardia, hypertension, hyperthermia, tremors, and hallucinations. Next. So the main life-threatening toxicities are the neurotoxicity and the cardiotoxicity. Next. So for the seizures, it's caused by the active metabolite, the hydroxybupropion. And as we said, this is the metabolite that has a 20 hours half-life. So the risk of seizures can be delayed. Next. And this risk is dose dependent. So after 3 grams, the risk of seizures increases. As for the cardiotoxicity, what is unique about bupropion is that it is not a sodium channel blocking agent. So it does cause widening of the QRS, but it will not respond to sodium bicarb. This is because it works by inhibiting the gap junctions. And gap junctions are basically connections between the myocardial cells that allows for depolarization. So once it blocks them, what it can lead to is widening of the QRS, arrhythmias, and eventually weakening of the muscles causing cardiogenic shock. Next. So bupropion causes toxicity based on the level. The normal therapeutic ranges is 150 to 450. Seizure risk increases after 3 grams, and cardiac toxicity increases after 10 grams. Next. So our patient actually took 13.5 grams. He was already at the cardiac toxicity level. Next. So we'll quickly review the management strategies. There are 4 management strategies. There is early decontamination. Our patient had received activated charcoal, but I think with this high volume, there was also room for whole bowel irrigation. Supportive care, seizure control, the usual seizure control with the consideration of avoiding phenytoin as it is also a sodium channel blocking agent. And for the cardiotoxicity management, we'll discuss it now. Next, Samia. Okay. So the treatment here was intralipid infusion. This is because bupropion is lipophilic drug. So the intralipid infusion will act as a lipid sink. Okay. And if the patient is peri-arrest, VA ECMO can be considered if you are at a facility that has it. Next. This is one of the first case reports that discuss the use of lipid emulsion from bupropion and lamotrigine. Next, Samia. And as you can see here, this is the patient that overdosed on this drug. So if you can see here on the y-axis was the systolic blood pressure. She went into cardiac arrest and her systolic blood pressure remained low up until intralipid was given, and that's when the patient started to respond. Next. And this is just a summary of the toxicity, going from having no symptoms, followed by seizures, eventually cardiac toxicity, including widening of the QRS and cardiogenic shock, and eventually they go into cardiac arrest. Next. And the final slide is venlafaxine. A lot of the audience mentioned serotonin syndrome, and that is correct because the patient did take venlafaxine and he fulfilled the Hunter criteria for serotonin syndrome. He had an inducible clonus, he was agitated, diaphoretic, and he met the criteria. However, serotonin syndrome was not the killer in this overdose. Next. So just to summarize, always identify your toxin because we knew that this patient took bupropion. Remember that this patient, your patients, if they overdose on it, they're at risk of seizures, and these seizures can be delayed because of the long half-life. Cardiotoxicity is not due to sodium channel blocking, but it's actually due to gap junction inhibition. And of course, always consult your local toxicologist for guidance and consider co-ingestions. Next.
Thank you so much,
thankfully,
dear.
despite the massive overdose, our patient walked out of the hospital neurologically intact.
Yeah, fortunate. Yeah, alhamdulillah. Thank you so much, dear, for this instructive case presentation. And thank you so much. And then for all the details for this, also etiology and for the drugs as well. Thank you so much, Dr. Hiba. Professor Nuzha, we can and like I'm happy that our audience waited for us after 6 o'clock UAE time. So just we will be now, fast in this to conclude the session. Before that, just I would like to let Professor Nuzha share with us. I would like to ask her a question regarding this, massive ingestions of extended release formulations, which is really different than immediate release. So these often present with the deceptive window of early clinical stability. Sometimes we will think, no, the patient is lying. Maybe the patient took less than the amount, reported. However, this it will give you, false reassurance about, this or underestimation of the risk. So this patient. So my question is, for these, massive ingestions for extended release formulations, with this deceptive window of early clinical stability before rapidly progressing to status epilepticus or other cases. So what specific continuous monitoring parameters or prophylactic critical care interventions do you mandate during this latent phase to anticipate and mitigate sudden neurological or cardiovascular collapse? And also for sure, for any other insights you would like to add for this patient, patient or this poison.
Thank you, Samia. Donc, it is a very interesting case, and I'm very happy that this molecule, the Bupropion, is not available in Tunisia. But I learned a lot about this case when I was in MENATOX. I will be very brief here. I will insist to three things. At first, for Caesar, we have to give benzodiazepine, then barbiturate. Phenytoin must be must be not recommended because of it can enhance the cardiac toxicity. Second, here for the cardiac abnormality and the cardiogenic shock, here antiralipid infusion is the solution because of the mechanism of toxicity, because there is a gap junction inhibition, but not a channel inhibition. That's why molar bicarbonate is not efficient. At third, I think that here I don't know if this patient got gastric washing or not, because here I think gastric decontamination must be here. We can do this because we have sometimes to eliminate this product. I think charcoal, activated charcoal, and gastric washing must be mandatory here. I think it is very interesting. And at the end, if the shock is refractory after antiralipid infusion, here the indication of the ECMO is the solution for the patient, because the situation could be very dangerous and the prognosis could be very very bad. Yeah.
Yes, I agree. Actually, thank you so much, Professor Nuzha. I agree on point about the point of ILE, the intralipid emulsion. Maybe I don't know if the audience are they had experience with that. If they are familiar with that, with the ILE. So the ILE for this case exactly, it works at the dual mechanism or mechanistic theory. So it's having two things: the efficacy first to reverse the refractory cardiogenic shock. This is first, but however, we have the highly lipophilic bupropion molecule itself. So it is the prime candidate for this lipid sink phenomenon, because it's like the lipid will take the molecule out and keep it like in a sink or captured to not have this activity, to be inactive. So when we consider like we have, it's a 20% lipid emulsion that we need to administer, and this will create the expanded intravascular lipid compartment, such as a new compartment there that actively partition and sequesters the lipophilic parent drug and its active metabolites as well away from the target myocardial tissue, effectively lowering the free drug concentration interacting with that cardiac gap junctions. Furthermore, beyond this simple pharmacokinetics work, so the ILE exert the profound direct metabolic effect on the failing myocardium. So in states of toxic cardiogenic shock, The stressed myocardium is often starved of its primary energy substrate. So this is also the infusion will load and provides the immediate and abundant source of free fatty acids as well to help the myocytes rapidly utilize this oxidative phosphorylation to restore the production for the ATP, etc. And then, so this is, I mean, the work of that. So when we think about the adverse effect, massive lipid load is not without adverse effect. However, when we give this large, we are, I mean, treating a life-threatening condition. That's why we actually recommend it for this situation, for massive overdoses. Thank you so much for the audience. So this is recorded in MENATOX. You can, Mohamed, you can access in the MENATOX website. It's a recorded session, sorry. And then we, so we can, actually, it's 6:20. So maybe we need to wrap up, guys. So Professor Nuzha, you want to answer any question here before we wrap up?
I think we talk about all the situation here, and I don't know if there is some question. I don't see any question.
Yeah, here so yeah, we mentioned that tool, paracetamol. Paracetamol, actually, for any suicidal patient, guys, you need to do it. Paracetamol, salicylate. If patient is inebriated, you do ethanol as well. These three things you need to do for any patient, suicidal patient. You need to do these tests. Yeah, so there is a question regarding past surgery that he had gastric sleeve. Does it has impact on this case? Actually, this case is a massive overdose. So any condition, any normal patient will have this severe presentation because it's massive overdose actually. What we have also another question. I think we read all the questions. Thank you so much. Let us conclude the session. Thank you so much for staying here and for your I mean active participation in this session, and hope to see you all in our poison hour next. At the end of this month, we will speak about snake bites. It's a really, really interesting topic. Webinar presented by Dr. Afra Suwaidi. I will be, inshallah, moderating it. And then next month, inshallah, every month you will have this, in the second Tuesday, you will have the MENATOX Clinical Rounds, and in the last Thursday, you will have the poison hour. So stay in touch and be safe. Thank you so much for being here. Thank you so much for Nuzha Brahmi.
Thank you. Thank you.
Thank you so much
Thank
for
you, Samia. And I think for the next time, the case will be from Tunisia, I think.
Inshallah, marhaba, inshallah. Thank you. Thank you.
Thank you very much.
Thank
And
you
goodbye
all.
for everyone. Thank you.
Thank you all.